Good afternoon, everybody, and welcome to the NGPG Quality Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment, and you can enter your questions into the Q&A section. If you're looking for the event survey, that will be shared in the chat section toward the end of the talk. And now it is my pleasure to introduce our speaker. Gabriel Velez, MD, is a PGY4 Chief Resident for the Internal Medicine Program here at Northeast Georgia Medical Center. In his current role, he works with the research department and also serves as a guide for residents during their grand rounds, journal clubs, and teaches on internal medicine topics. He's in the process of applying for cardiology fellowship and will be discussing hypertension management today. Welcome, Dr. Velez. You can take it from here.
Thank you, Suzanne. Good afternoon, guys. So I'll be talking about hypertension management and control. So we'll be talking about the guidelines and kind of moving that to the real world practice. So I currently have no disclosures. I wish I had some, but maybe in the future. So my objectives, we're going to review some of the latest hypertension definitions and 2025 guidelines, which just came out this year, earlier this year. We'll evaluate some common challenges in hypertension management, talking about resistant hypertension and kind of treatment inertia. Then we'll identify some evidence-based lifestyle modifications that can reduce blood pressure and improve long-term cardiovascular outcomes, select our appropriate pharmacological therapies, and then we're going to talk about how do we implement some strategies that can help patients adhere to medications and treatments, engagement, and then blood pressure monitoring, especially in the outpatient setting. So real quickly, so why do we care about treating high blood pressure, right? So if we look at the left, we can see a trend that cardiovascular death was increasing in the United States from the 1900s to 2022. Then it kind of started downtrending and we're headed towards an increase again. So if we look on the right, we can see that hypertensive disease actually accounts for about 14% of these cardiovascular deaths. So this is a really high risk. So we need to treat this, okay? So again, if we look at here on this graph, earlier in the past few years, they've been talking about this prevent equation. And if we look at this prevent equation, it has blood pressure management right there at the center. And what this prevent equation is, it takes into account different lab values, which we'll talk about later in this presentation. But it's used in patients without any cardiovascular heart disease, stroke, or heart failure, and it's mostly used in ages 30 and 79. It can estimate absolute risk, and this can help clinicians and patients and their sure decision-making for interventions. Now, something really important that this equation takes into account, which other equations do not, is that it makes you check your microalbumin fraction ratio in these patients, and we'll talk about later on why this is important. And it also can be used in patients to determine their risk for heart failure. So another thing earlier is that when this prevent equation came out, compared to ASCVD risk equation, it was actually under-treating patients. But then when you add something like a zip code, which determines kind of the, like where the patient lives will determine their availability to get healthcare, their economics, and all these social determinants of health, then it actually increases the treatment in patients that would normally not be needing treatment. So we'll talk how this impacts later on. So this is the prevent equation, really simple. I just filled it out. And then let's say 10-year risk of cardiovascular disease was 2.6%, and then the 30-year estimated risk. And then the zip code is to determine the social drivers of health information. And this is available for free online. So let's talk a little bit about previous clinical trials. So this is a trial by Rahimi that was published in Lancet 2021. if we can look at both graphs here, we can see that actually a 5 millimeter of mercury reduction in SBP actually reduced the risk of major cardiovascular events by about 10%. And this is irrespective of any other diagnosis of cardiovascular disease. And these findings suggest that this pharmacological blood pressure lowering is similarly effective for primary and secondary prevention of major CVD disease, uh, even if at blood pressure levels that are currently not considered for treatment. So it actually showed that some patients, even though they don't meet the criteria for treatment, if you actually lower that blood pressure, you can reduce their risk of cardiovascular disease, which is really important. Another meta-analysis here, this took into account multiple randomized control trials, and basically they determined the hazard ratios for major CVD events. Uh, and this were actually proportional to the magnitude of systolic blood pressure reduction. So, and this was actually similar without any, like in all the patients that didn't have any similar cardiovascular disease. And it also showed that an average reduction of 5 millimeters of mercury in SBP, again, would decrease the major cardiovascular events by about 10%. The most important trial here was actually the SPRINT trial, which was the only one that proved that targeting an SBP of less than 120 was more effective in reducing the risk of major CVD events. So again, why do we care about all these trials, and what can this show us after the trials? So this study in 2022 actually evaluated the patients that were on these trials, and then they kind of followed them up and kind of saw, okay, let's see the mortality when they're in the trial. Let's see the mortality when they're in the observational phase, and then let's follow them up passively and see what they do after the trials. So that's them following up with their primary care physicians or not following up. Some of them were lost to follow up. So they actually showed that uh, the patients that were randomized to intensive treatment, average blood pressure before starting was 132, and then this was after like 5 years, and then 140 after 10 years. So after the trials, they saw that the blood pressure starting going up, meaning that either they were not following with their primary care physicians or they got lost to follow up. And then the mortality actually increased again. So basically, if you do not follow the intensive treatment of blood pressure, your mortality increases back to where it was. So it's like you haven't done anything. So after 10 years of follow-up, the mortality benefits of the trials is just dissipated. It discontinued. So this is, very important because uh, it just tells us that we need to implement more intensive blood pressure treatments in our clinics and in the outpatient world. So let's talk about this trial. So this recent trial on hypertension, the ESPRIT trial, this was done in China, which is a different population than us, but nevertheless, this is one of the first trials to include diabetic patients and patients with previous strokes. So they had previous cardiovascular events, and they did intense SBP lowering to less than 120 versus standard treatment among patients with cardiovascular disease, with or without diabetes or previous stroke. And it actually showed that targeting an SBP of less than 120 when compared to less than 140 prevented a lot of major vascular events. This was statistically significant, and it had minor excess risk. So that means they had very low risk of orthostatic hypertension or electrolyte abnormalities, among other side effects. If we look at this graph, we can see primary outcomes, major cardiovascular events. If we look at the graph, it shows us that it leans toward intensive treatment to prevent mortality, all statistically significant. And then if we look at secondary outcomes, that from any cause, it also leans toward a more intensive treatment. There is less risk of primary and secondary outcomes as well in the intensive treatment cohort. Another one of the newest trials, and this was in New England Journal of Medicine in 2024, the P-BROAD trial, also done in China, but again, it shows that patients with type 2 diabetes, elevated SBP, the incidence of major cardiovascular disease for up to 5 years was significantly lower and intensive treatment strategies to lower SBP to less than 120 when we compare it to less than 140. So we again and again we see the benefits of intensive treatment versus a standard treatment right now. So let's look here at scope of the problem. So then this is the NCHS database. And if we look at the prevalence of hypertension, adults 18 and older by sex and age, we can see the hypertension affects almost 1/2 of the US adult population. So this is, again, an important risk factor for cardiovascular disease. If we look at during 2017 to 2020, 48% of adults had hypertension. And more than 1/2 reported taking medication to lower their blood pressure, but only 1/5 had their blood pressure under control to less than 130 over 80. So if we kind of round this up, nearly half of US adults have high blood pressure. 3 in 4 adults with high blood pressure do not have it under control, which is currently defined as less than 130 over 80. In 2023, high blood pressure was a primary or contributing cause of more than 500,000 deaths in the United States. The annual cost is estimated to be about $219 billion in the USA, and this was in 2019. So I suspect that it's even higher today. And as a preventable and treatable risk factor for CVD, about 1 in every healthcare dollar is actually spent on cardiovascular disease. So by treating hypertension, we can actually start decreasing this. And then in 2018, national per capita Medicare costs show that beneficiaries living with heart disease or having a stroke they were using about 19,000 and 31,000 respectively. So let's look at this. So we're going to chime into the new 2025 hypertension guidelines. So let's look at this. So they change basically how they basically divide the categories. So now they want you to kind of call it normal, elevated, and then you kind of switch to that stage 1 and stage 2. And it is useful to categorize blood pressure levels. And this is just for clinical and kind of public health decision making. So we have 4 levels based on the blood pressure that is measured in the healthcare setting. And then an increasing number of individual studies and meta-analysis have reported that a gradient of higher CVD risk from normal blood pressure to elevated blood pressure. And as it goes up, you have more risk of CVD. So we can say that among middle-aged and older adults, the prevalence and risk associated with higher SBP are actually greater than those associated with higher diastolic blood pressure. So how do we diagnose it? So class 1 recommendation says that when diagnosing or managing high blood pressure adults, standardized methods recommended accurate measurement and documentation of in-office blood pressure. So when hypertension is suspected or confirmed, you got to do a comprehensive medical history. You do your physical exam. You get laboratory tests, which includes, your EKG, CBC, your chemistry profile, lipid profile. You can either do fasting blood glucose or A1C, thyroid stimulating hormones, UA, and then your urine albumin creatinine ratio, which was added to the preventive risk calculator, which the guidelines actually recommend to use to treat hypertension in patients now. And it is useful to identify any contributing causes of elevated blood pressure, including secondary causes, which we'll talk about later in the presentation. And also, you should check basic laboratory tests every year at least, or sooner if the patient have medication intolerance, you suspect electrolyte imbalances, or note any uric acid changes. So one of the things, so why urine albumin creatinine ratio now and not before, right? So the urine albumin creatinine ratio gives you an earlier identification of a patient that has developing or worsening CKD than the serum creatinine. Because while other tests like the GFR test can assess the kidney function based on blood creatinine levels, the urine albumin creatinine ratio can look at protein levels in urine, and it can detect early kidney damage. And it's not affected by a person's muscle mass or lower muscle mass. It's not affected by anything that overestimates kidney function. So It's just a better test to determine CKD in a patient. So more again on diagnosis. So out of office blood pressure measurement, either using ambulatory blood pressure monitoring or home blood pressure monitoring, it can provide valuable information to you for you to confirm and manage hypertension. So we can see that greater number of blood pressure measurements obtained in the office setting can enhance accuracy, precision for detecting a patient's true and usual blood pressure. Again, pertinent laboratory tests repeated annually or before, depending on what you suspect the patient's undergoing, like any worsening of disease or electrolyte imbalances. And then EKG can provide any important information on subclinical CVD, like left ventricular hypertrophy. You can check like cardiac biomarkers, echocardiography, or any coronary artery calcium scoring to kind of estimate the risk for CVD on patients that have more risk factors and not just hypertension. So this is a picture, a very good picture from the new guidelines. They just show how to get the blood pressure measurement in the office. Most of the attendings, obviously, and staff know how to do this. So we always kind of like to wait for at least like 30 minutes before measurement. And if we can't wait, we kind of recheck the blood pressure once the patient's calm and you've talked to them during the office visit. But you always want to have a validated device. And I'll talk more about some websites that actually show some devices and some companies that have really good validated devices because of their accuracy. Use the correct cuff size on the bare arm. Patient's arm should be supported at the heart level. Make the patient relax. Sit back in a chair. Put your legs to the ground. And then you can kind of like rest. Don't talk during the measurement, or it can cause some discrepancies. And you should also take 2 or more blood pressure measurements at least 1 minute apart to kind of see what the average is. Now, when the patient is at home, it's a little bit different because you cannot control for these factors. So you have to trust that the patient's actually doing it correctly. So you have to sometimes ask the patient what blood pressure cuff they are using. If there's a lot of discrepancies with the blood pressure measurement at the office, sometimes you can tell them to bring it and make sure that it's actually validated and kind of doing accurate measurements. Always teach the patient how to position themselves and the cuff, and then they should relax when they're taking their blood pressure measurement. And then they can share it either with a blood pressure log, or sometimes some of them can connect to Epic and give us all the information. So there's a good website called validatebp.org, and this website can actually show you all the companies and the validated blood pressure cuffs so that we can give more recommendations for patients. So one of the big ones in clinic is, white coat hypertension. So now a class 2A recommendation is that patients that have untreated SBP of more than 130 or a diastolic blood pressure more than 80, but have without office blood pressure more than 160 or diastolic more than 100, it is reasonable to exclude white coat hypertension using out-of-office blood pressure monitoring before a diagnosis of hypertension is made. So some meta-analysis have actually identified that there is modest reductions in office blood pressure measurements at 6 months and 1 year when you actually use the home blood pressure measurements. So it's a huge discrepancy. Also, observational studies have demonstrated that sustained normal tension and white coat hypertension is associated without no risk at all to a moderately increased risk of CVD. But nonetheless, the risk of CVD is higher in sustained hypertension compared to white coat hypertension when adults have elevated high blood pressure in the office. But again, like it says, it's reasonable to exclude white coat hypertension when out of office blood pressure measurements are more than 130/80. One caveat is that if you see a patient that comes into the office, they are relaxed, you keep checking in, your average is still a systolic more than 160 or diastolic more than 100, you actually should start treatment because the prevalence of white coat hypertension among these patients is extremely low. So it's actually beneficial to start treatment and titrate on these patients. Now let's switch some gears here and let's talk about resistant like secondary and resistant hypertension. So in these guidelines, we do have some class one recommendations, and it's that in adults with hypertension, screening for secondary causes of hypertension is recommended when you have a lot of clinical suspicion. If it's high, you should test to increase the rates of detection, diagnose, and then target some specific therapy. So screening for primary aldosteronism is recommended, even though they don't have hypokalemia, because this is actually not present in a lot of the patients. So if you kind of gauge your clinical suspicion based on this, you're going to miss a lot of diagnosis on these patients. So secondary hypertension is actually very common than we think in stage 2 hypertension or treatment-resistant hypertension or any like sudden onset of hypertension, any patients that are really young and they're all of a sudden hypertensive, or patients that were actually getting a really good treatment, they were controlled and now they're uncontrolled. Older adults with diastolic hypertension or any organ damage that you're seeing disproportionate to the levels of blood pressure, then your suspicions should be high. So these include primary aldosteronism and very commonly obstructive sleep apnea. And although it's really low, secondary causes can be identified in between like 5 to 25% of the time. This is a really good chart from the guidelines that really show you all the kind of suspicions that or conditions that can be associated with secondary hypertension. So if they don't really have those conditions present, then your screening is not really indicated and you would not have the clinical suspicion as well. But if they have those and you have high clinical suspicion, you start screening for aldosteronism and other secondary forms. If you get a positive screening test, then you can enhance your treatment or send them to a specialist if they have obstructive sleep apnea and they need to see a pulmonologist for sleep medicine, then you can send them there, for example. But if they don't, then you can enhance just your medication therapy and move forward. So let's talk about the big one here. So aldosteronism. So these disorders is basically increased aldosterone production, inappropriately high for your sodium volume status. Really important, hypokalemia is absent in most cases. And then in 2/3 of these patients, the excess aldosterone is actually caused by bilateral adrenal hyperplasia. Then 1/3 of patients with primary aldosteronism can be due to increased unilateral aldosterone production. So this is adenoma. And then this is just a really common cause of secondary hypertension, and targeted treatment can prevent your high risk of CVD and then improve kidney function. So this is a class 1 recommendation, class 1A. So patients with hypertension screened for primary aldosteronism is recommended when you have the presence of some of the things that they say. So like, for example, any condition that increases rates of detection, and so and so. So let's go here more on the recommendations. So unfortunately, the rate of screening for primary aldosteronism here in the USA is less than 2%. But then the prevalence of primary aldosteronism is about 5 to 10% in individuals with stage 1 hypertension, and then about 11 to 22% with stage 2 hypertension. Patients with primary aldosteronism, they typically have suppressed renal activity, so you will see less than 1 ng per ml, and most data supports that the plasma aldosterone concentration should be at least 10 to interpret the test as positive. The most used cutoff value for aldosterone to renin activity ratio is 30, and then the plasma renin activity in nanograms per millimeter per hour. Although some data support like a threshold of like 20 or 40. You should have patients unrestricted salt intake, serum potassium in the normal range, and ideally your MRA withdrawn for at least 4 weeks before testing. And then part of the guidelines, they actually show evidence that there is growing evidence that supports that primary aldosteronism occurs across the full breadth of hypertension severity. So even patients that are actually like not stage 1, they can have hyperaldosteronism. The thing is that once you start treatment, you will not figure it out until they are on multiple medications, and then your clinical suspicion starts increasing. So On diagnosis and management, so if screening results are negative or borderline in these patients, but you still have high level of suspicion, then you can temporarily substitute their medications to non-interfering medications like calcium channel blockers, vasodilators, or peripheral alpha blockers for at least 2 to 4 weeks prior to repeat testing. You can also may require aldosterone suppression tests, such as IV saline suppression tests or oral salt loading tests. And then if the diagnosis of primary aldosteronism is confirmed and the patient agrees that surgery would be desirable, then you refer them for an adrenal venous sampling. If there is unilateral excess aldosterone production on adrenal venous sampling, then you can refer them to unilateral laparoscopic adrenalectomy. Now, if the patient has bilateral increased aldosterone secretion on adrenal venous sampling, they don't want any surgery, or they're not actually a candidate, then you can treat with MRI, including spironolactone or Pleuronil. You also need to get imaging of the adrenal glands, even if treatment is going to be only with medication, because you want to rule out any large adrenal masses that may require adrenalectomy, or if they have any features suggestive of malignancy, like a size of more than 4 centimeters, and then imaging characteristics. Another one here is renal artery stenosis, more commonly seen in women as well, especially fibrodysplasia. But medical therapy is also recommended to reduce kidney and CVD mortality. So even though atherosclerotic disease in the renal arteries, they represent systemic disease. You probably have atherosclerosis in other organs, and this indicates higher risk of both kidney failure and cardiovascular mortality. No randomized controlled trials or any other observational trials, RCTs, have actually demonstrated any clear clinical advantage of doing renal artery revascularization over medical therapy among patients with hypertension. So the current recommended medical approach is using antihypertensive regimens that include a renin-angiotensin system blocker for you to reduce LDL with high-intensity statins, smoking cessation in smokers, and hemoglobin A1C reduction in patients with diabetes. And you can also use some antiplatelet therapy. For those patients that have worsening CKD or acute heart failure, then you can do renal revascularization only in patients that don't have non-atherosclerotic renal artery disease, like fibrovascular dysplasia, Takayasu arteritis in some cases, and hypertension, because this can be curative. And also fibrovascular dysplasia, more common in women, 90%, and you can see it in younger patients. So here, OSA, obstructive sleep apnea, not a lot of good recommendations, but still 2A. So in adults with hypertension and OSA who are overweight or obese, weight loss interventions are actually recommended. And now we have, CPAP, we have GLP-1s more recently, and they can actually benefit from that. It's actually covered by insurance as far as treatment for OSA. And then, so we look at lifestyle interventions. So this is basically weight loss interventions, nutrition for all of these patients with high blood pressure. Then when you start, CPAP therapy, it has been shown to lower systolic blood pressure by about 8 millimeters of mercury in adults with moderate to severe OSA. And then several RCTs have actually demonstrated short-term treatment with CPAP can reduce high office blood pressure, ambulatory blood pressure by 2 to 5, including individuals with resistant hypertension. But these outcomes are going to vary based on the factors of, individual factors like OSA severity, how much CPAP therapy the patient is getting, but it's still recommended to treat at least with a CPAP. So let's look at kind of the lifestyle modification that we currently, have. These are all class 1A recommendations. So achieving a healthy weight. So it has been shown that about 5% weight loss can increase SBP. If we look at the chart below, 1 kilogram weight loss is expected to decrease 1 millimeter of mercury average. If we follow a healthy diet, in a couple of months, you expect to see about an 8 to 14 decrease if we do reducing sodium intake, even if they don't have heart failure, to less than 2,300 milligrams per day, you can expect to see a 2 to 8 decrease. Physical activity, we do want to see that 30-minute at least 3 times a week, and then limiting alcohol, reducing stress can actually lower about 2 to 4. It's also important you guys can also look at the AHA Life's Essential Aids, where you can see a lot of lifestyle modifications that can help with cardiovascular disease management. So here are the new guidelines. So if we look at treatment, blood pressure thresholds to initiate medications aren't changed, but now they're using the prevent risk score. So if we have a patient with stage 1 hypertension that does not have CVD, CKD, or type 2 diabetes, and their score is less than 7.5%, you should start with lifestyle modifications. And then after 3 to 6 months, if the SBP is more than 130, you add medication. So the goal is to be less than 130, but encourage your patient to try to achieve SBP of less than 120 because of all the data that the trials have shown. So there's another one of the charts which we'll be talking about. I know it's a little bit of a big chart, so let's move forward here. So pharmacological management, all adults with hypertension, initiation of medications to lower the blood pressure when SBP is more than 140 or diastolic is more than 90. Adults with hypertension and clinical CVD, it's recommended to initiate medications to lower an SBP of when it's more than 130. And then again, like I said before, the prevent risk score, if it's more than 7.5% and the patient has an SBP of more than 130 or diastolic more than 80, medication management is recommended. And also the prevent equations, it's validated only for patients aged 30 to 79 years, which kind of represents the most generalized risk population. And it's actually the most accurate and contemporary prediction tool available. So this is another kind of thresholds to initiating blood pressure treatments in adults, which we already talked about. And this is just doing a summary of what we talked about, the prevent risk score and the SBP and diastolic blood pressure goals. So what medications do we choose to treat these patients? It hasn't really changed. So we still have the same medications like thiazide type diuretics, long-acting hydroproteic calcium channel blockers like Norvasc or amlodipine. ACE inhibitors or ARBs are recommended first-line therapy, especially in patients with heart failure or any cardiovascular disease. So when you initiate pharmacological therapy, you have to consider the comorbidities. Do they have CAD? Do they have heart failure, stroke, diabetes, or CKD? Because this is going to change your management on the class of medication you will choose. But still, we have strong randomized control trial evidence supporting these 4 types of medications. We have also seen that in JAMA, there's a trial that was carefully designed to compare long-acting thiazide-type diuretics with other calcium channel blockers and ACE inhibitors, and medications like chlorthalidone, which is a long-acting thiazide, actually showed more effectiveness in prevention of heart failure. It was slightly better than ACE inhibitors for prevention of strokes as well. Beta blockers should only be reserved for adults with compelling indications if they have atrial fibrillation or any other comorbidities than like heart failure, then you will need to put them on beta blockers. But as far as primary selection of medications, you will not use beta blockers. So let's talk about if you're going to use monotherapy versus combination, right? So if they have stage 2 hypertension, their blood pressure is 140 or higher, diastolic is more than 90 or higher, you can actually choose a 2 combination pill. So let's say lisinopril and hydrochlorothiazide combination. And this can actually not only improve the blood pressure, but it can improve adherence. This way, the patient does not have to take 2 medications and get confused or kind of miss doses. So this is where the problem of kind of medication adherence comes in. So strategies, choosing medication dosing that is maybe like one time a day instead of like multiple times a day. When you're going to choose more than one medication, use a combination pill to improve medication adherence. Because studies have actually said about 50% of patients do not adhere to the antihypertensive medications after 1 year of treatment. Uh, but they have shown that there is significantly higher adherence if you choose a morning dose, like 6 a.m. to 10 a.m. versus an evening dose. Uh, they also have shown that medication like reminder aids, or they get like text or a smartphone app, patient education, and like mindfulness-based stress reduction or counseling or treatment of anxiety can also improve adherence strategies. So, summary of this: so dose consolidation, single pill combination, education and coaching, electronic home blood pressure monitoring and feedback, um, medication synchronization, reminder aids, and then self-management interventions. Also, like patient preference and shared decision making can actually help the patient feel motivated that they're taking care, part of their own care. So this can improve adherence. So here, once we dive into, okay, we started medication, we implemented our strategies for adherence. Now we got to decide what are our goals for these patients. So as we talked before, adults with confirmed hypertension or increased risk for CVD using the prevent risk calculator, and they don't have an, they have an SBP call of at least less than 130. You should actually encourage them to be at less than 120 to reduce your cardiovascular events and total mortality. The patients that have hypertension and are at increased risk for CVD, a diastolic blood pressure target of less than 80 is highly recommended, again, to reduce cardiovascular events and total mortality. And when we get to patients with diabetes, randomized controlled trials like the ones we discussed before, like the P-BROAD, have shown the benefits of an intensive blood pressure control regimen, specifically in type 2 diabetes patients. So that would be an SBP of less than 120. We can use any of the recommended drug classes like ACE inhibitors, ARBs, and calcium channel blockers and diuretics for treatment of hypertension in diabetic patients. But we do know that ACE inhibitors and ARBs have greater efficacy in reducing their chronic kidney disease, their urinary albumin excretion, compared to the other drug classes in these patients. If we have patients with CKD, including those with albuminuria, which would be more than 30 milligrams or more than 30 in a 24-hour, then the trial evidence shows that you have more benefits with ACE inhibitors or ARBs. And now more recently, SGLT2 inhibitors, GLP-1 receptor agonists, they have also been shown to decline kidney like slow the decline in kidney function, whether you have diabetes or not. And this way they have shown that they can kind of help with blood pressure management, but this is more on the sidelines, not your primary treatment. When you have patients with heart failure, we do know the 4 classes for GDMT. You also want to treat that SBP to less than 130 to lower that risk of developing heart failure. And then in adults with diastolics, you want to treat it at less than 80 to again lower that risk of heart failure. Because trials have and observational studies have shown that hypertension is actually present in 71% of patients with heart failure. And the presence of hypertension in people less than 40 years of age is very highly associated with developing heart failure in your life. So there's a dose-dependent association between blood pressure level and heart failure risk. So you do want long-term treatment of systolic and diastolic hypertension to reduce the risk. In the SPRINT trial, we saw that targeting an SBP of less than 120 improved the primary outcomes and actually improve the incidence of heart failure. So we do want to emphasize and strongly treat these patients. Once they have heart failure or they have heart failure with reduced ejection fraction, then things change. They will have low blood pressure only because eventually they develop vasodilation, unfortunately. But the medication management, you are going to be using not only ACE inhibitors or ARNI or ARBs, you will be using MRAs, beta blockers, and SGLT2s. Now, in patients that are African Americans or they cannot tolerate these JDMT medications, then you will use hydralazine and isosorbide dinitrate to treat these patients. But the data has only shown mortality benefit in patients that are self-identified as Black. Now, what if a patient has CKD, they have elevated blood pressure? You can still use ACE inhibitors and ARBs, and you should expect, sometimes your eGFR to decrease. That is a transient dip, and you can see it up to 30%. But this is short term. This should not kind of lead you to discontinue this medication unless you see recurrent lab values that are showing that kidney function is worsening and the patient's headed towards the wrong direction. You should also check electrolytes every, 2 to 4 weeks after initiating medications or intensifying medications. You want to make sure that there's no abnormalities there. And even though, some patients might have a GFR less than 30, you can still continue their ACE or ARBs. There are some randomized control trials that found that discontinuation is not associated with significant difference in long-term decrease of GFR and mortality. So it's beneficial to just continue these medications. So this is something really interesting. So patients that have uncontrolled blood pressure, we do know that they have higher risk of dementia. So, some studies show that about 9 million Americans can have dementia by 2030 and nearly 12 million by 2040. And we have identified hypertension as a preventable modifiable risk factor because this is related to, small vessel ischemic disease, cortical white matter abnormalities, and this is very highly predictive of cognitive decline and dementia. Most observational studies suggest that better control of SBP reduces Alzheimer's disease and related dementias. And we have seen that by controlling blood pressure, you can decrease the risk up to 19%. So that is really good. We have also seen that the Sprint Mind legacy has shown that reducing the risk of you can reduce the risk of mild cognitive impairment alone with or without dementia for at least 7 years when you control blood pressure to an SBP, not only less than 130, but with that goal of less than 120. So again, when we have resistant hypertension and we want to treat these patients, we want to replace medications like diseptide diuretics with chlorothalidone, which is more long-acting. We can add spironolactone or eplerenone, and then we can add other agents secondary to this, like beta blockers or non-hydropyridines, calcium channel blockers, if they have elevated heart rate, add potent vasodilators, and then if nothing works, then refer to a specialist, especially like we talked about, if they have diagnosed secondary causes like atherosclerosis of the renal arteries, or if they have primary aldosteronism for further treatment and management. Now here a little bit about renal denervation. This is kind of what the future is showing we're headed towards. Now we do know that benefit of renal denervation for isolated systolic hypertension or advanced chronic kidney disease is really uncertain. Most trials have only included patients with elevations in both systolic and diastolic blood pressure and a GFR that is at least more than 40. Among patients with resistant hypertension, the magnitude of SBP reduction when they get renal denervation is actually inferior to just using medication and spironolactone. So no really good benefits on randomized controlled trials. In addition, patients might get a difference between 3 and 8 millimeters of mercury, as was shown in trials. And then the presence of renal artery disease is considered a contraindication to the procedure. So predictors of blood pressure response when they get renal denervation have not been consistently demonstrated among clinical trials. And you also have to determine as well if patients get renal denervation, the whole system doesn't respond as well as a normal patient. So if these patients get, let's say, septic shock, are they actually going to be as a good response to medications to treat them as compared to patients that did not get renal denervation? So those are things to actually consider as well. This is just, again, another summary of the treatment of severe hypertension and then hypertensive emergencies. We do know that we want to decrease these blood pressures about 25% and then go slowly thereafter, unless they have like aortic dissections, then we want to decrease that blood pressure immediately. Or if they have hemorrhagic strokes, then we don't follow that rule of 25%. Now let's go here. So future directions, now we're kind of seeing population management strategies that are utilizing the electronic health record, more community engaged strategies to identify patients that have undiagnosed or uncontrolled hypertension so that we can kind of tailor our resources. There's a lack of evidence to support blood pressure targets for diastolic hypertension, which is more common in younger adults who have like low short-term CVD risk, but have longer time horizon to consider for prevention. So we need to do more studies on these patients. We need more studies to tailor our blood pressure management in patients with different race, ethnicities, patients that are underinsured or uninsured, to allow more precise predictions for needs and better focused prevention strategies. So we need additional data as well to like monitoring to evaluate new approaches and effects on blood pressure control, CVD outcomes across differences in sex, gender, race, ethnicity, socioeconomic status, educational level, and their access to medical care. We also need studies to understand the role of genetics and epigenetic factors in blood pressure. And we did initial trials to compare different combinations of medications, if combination pills versus single pills is better or not, and then how the patients tolerate these combinations of medications. We also have seen more roles of tech. So there have been hospital systems that have implemented mobile apps with blood pressure machines at home that connect to the Epic system. That way physicians or nursing staff can see live updates on blood pressure management, and you can do televisits instead of waiting months and months for your patient to come to clinic, and you can further improve management. We need to do more community outreach, and we can also use our 24-hour ambulatory blood pressure management to diagnose mass hypertension more effectively. And then my reference, it was mostly the 2025 guidelines and their associated references.
Thank you everybody for joining today. See you next time.